Now, the next speaker I have the pleasure of introducing, which is slightly weird because it's myself. So my talk is about diplopia, when to worry, and I will be back to answer any questions. So do feel free to put them in the question and answer section. Thank you. Thank you very much for asking me to speak at this webinar tonight. And I'm going to be talking from the orthoptist's point of view, supporting a busy A&E. And we're going to think about diplopia, when we need to worry. The first thing to do is think about when a patient arrives, do they have monocular or binocular double vision? And this is usually easily done by testing, looking with both eyes open and then under monocular viewing conditions. And you may get monocular diplopia in patients who have cataract, corneal, or macular problems. And these are the ones that we're not thinking about tonight. I want to think about the patients who have binocular double vision. Now, taking a good history is absolutely vital. And it may well be that the patient gets double vision immediately after they've had some trauma, maybe been in a road traffic accident or a fight, or it may be that they can say they have no understanding of why their double vision has occurred, and it's come on either very suddenly or of a gradual onset. And this is very important. If the patient knows exactly the time, maybe when they were watching their favorite television program, that they suddenly got double vision or they woke up with it, we'd describe this as a sudden onset. And this is often thinking about a vascular cause. If they have a gradual onset, then this could easily be the growth of a space-occupying lesion giving them a problem and getting gradual double vision, which is increasing. There are, of course, a group which are variable, and this can be decompensation of aphoria or a variable disease such as myasthenia gravis or thyroid eye disease. Myasthenia typically much worse in the evening when the patient is tired, and thyroid typically worse in the morning when the patient's lain flat overnight and their muscles have become engorged. Now, we've already spoken about sudden onset, and one of my direct questions to patients with double vision from casualty is, do they have hypertension or have tablets to control their hypertension? Are they diabetic, or are they on a statin or have high cholesterol? Some people, when they're actually being treated for a disease, don't consider they have it anymore. So it's very important to ask both whether they have the condition or they're being treated for it. And these are our groups that we, if they have a sudden onset, gives us some comfort that we are probably looking at a vascular problem. The next question I'd like to ask is the patient above or below 60 years old? And if they are of sudden onset but under 60, we still can consider a vascular cause, but it may also be demyelination or a change and increase in intracranial pressure or something such as an Arnold-Chiari malformation. In over 60s, if they have a vascular risk factor such as diabetes, hypertension, or high cholesterol, then our threshold for actually actively investigating these patients is much lower. So the next thing as an orthoptist is to look at eye movements. And here I'd be looking at a cover test for near and distance, considering that if you have an esotropia, which is worse in the distance, it's often a sign of a 6th nerve palsy, and very carefully examining ocular movements, including fast eye movements, saccades, and vestibular function if we think there's a supranuclear squint present. The other part of my job at this point is to carefully measure the eye movements, and this can be done with prisms or a Hess chart, and then making the patient comfortable. So if they have walked into casualty with double vision, we want to use a prism to relieve their double vision or move their eyes and single vision into a useful area for them. And if this isn't possible in a very incomitant squint, then using occlusion is often very useful. Now, I'd like you to look at this first video of me. It's a young girl, so she's under 60, and we would be thinking that we need to investigate her double vision. And she's complaining that she gets blurred double vision when she looks to the side. Now, if we look at her eye movements, when she looks to the right, she buries sclera on both sides, and this looks okay. When she looks to the left, you can see that she's not burying sclera on her right eye, and her left eye has nystagmus in it, an abducting type of nystagmus. And on elevation, she also has some gaze holding nystagmus. I want you just to watch that again and look at her nose as you're actually looking at her eye movements. This will mean your cones are fixed on her nose, and your rods can see the movement of the eye and how distrugate that eye movement is. She's getting double vision. She's also getting oscillopsia. And that's a limitation of adduction with abducting nystagmus. So we're thinking that this is a right INO. And when she elevates her eyes, you can see that she's got that gaze holding problem. I find that very useful because we know an INO is a lesion in the medial longitudinal fasciculus. But if she has that gaze holding nystagmus, it's much more likely to be a true lesion than a lesion that is due to myasthenia gravis, which can mimic this condition really rather well. I've already said I like to examine saccades in eye movement cases. And here you can see when you look at her horizontal saccades, how distrugate that movement is and how she's getting a slow adducting saccade and a very hypometric saccade in her left eye, depending on how the nystagmus is. And you can see how disorganized this eye movement is to her. This is one of the eye emergencies that I am always on the lookout for. This lady came into casualty and she said she had got a bit of double vision, but that had gone now because she had a ptosis. She was complaining of great pain, and that's not the sort of pain where you have a slight headache. These people often complain that they have power tools in their heads. And you can see from the picture here that if we lift her ptosis, her eye is classically down and out with a large pupil, and she has a third nerve palsy due to a posterior communicating artery aneurysm. So we would do an MRA on the same day in our hospital, but the imaging you use depends on the neuro center that you're at and what you can get. And if we look at the angiogram here, you can see there is the aneurysm, and in 3D reconstruction, it's really rather beautiful and showing there. So when we're confronted with someone with double vision, if they're mainly saying it's horizontal, you can think about INOs as we've seen, but also 6 nerve palsies and gaze palsy problems. And in vertical, think about 4th nerves, 3rd nerves, dorsal midbrain syndrome, and skew deviation. This is one of the conditions that often catches A&E and orthoptists out, and it's myasthenia. This patient actually comes in and presents rather like the lady we've just seen with the third. She has double vision, she has ptosis, but she has a very variable pattern, which makes us think of myasthenia. Remember, this can be variable on a day-to-day basis or a minute-to-minute basis. And if we put some ice in a glove and put it over the eye for about 2 minutes, this has a dramatic effect on myasthenia. Whereas if we just rest her eye for a couple of minutes, there is not such an improvement. In fact, she's almost practically the same. So this is a positive ice pack test for myasthenia, and is very useful when you're trying to find out if the eye movements are due to that. Had a sudden onset of horizontal double vision, and you can see that that's due to her 6th nerve palsy. In the primary position, she has a small ESO. When she looks to the right, she has no double vision and she looks okay, but in left gaze, she's got a -4 limitation of her abduction and her lateral rectus. And she was known to have high blood pressure. She was over 60, and so we thought we wouldn't actively investigate her. We sent her back to her hypertensive physician to say that she may need some help with that. And we did an ESR to think about temporal arteritis, but that was negative. We fitted her with prisms and we saw her in 6 weeks. Now, it's very important with these patients that they actually start to improve within 6 weeks if you've given them the label of vascular diplopia and vascular 6. She had no improvement, and so we did investigate her, and actually her 6 was due to a meningioma in her cavernous sinus just behind her left eye. And the reason it had come on suddenly was she just bled into that. So it was a vascular event, but we needed to drill down when she didn't get any better to find her meningioma. So I'm thinking that actually when a patient comes to you, if they are under 60 with double vision, you really need to think about investigating them, particularly if they don't have diabetes, they don't have hypertension or high cholesterol. And this would involve looking at their discs and scanning them and thinking about multiple sclerosis, maybe myasthenia, space-occupying lesions. And we know that sadly 6 can come on from secondaries from breast cancer in young ladies, for instance. So a real proper investigation to why they've got their double vision is important. If they are over 60 and actually have a risk factor, then we would, like the previous lady, investigate in 6 weeks' time if they hadn't improved. I hope this gives you a guideline of when to worry when diplopia arrives in your department. Thank you. I'm so sorry, I have just joined because the my internet went down, which is an absolute nightmare. Are there any questions for me?
May I ask a question?
Of course, Seema.
What would you do if, say, you had a patient that came in the middle of the night and under 60 with sudden onset of diplopia? And the reason I'm asking this, Liz, is that that's usually when they come, in the middle of the night. So what would you want the junior ophthalmologist in the department to do in terms of investigation and stuff? Should they wait till the morning? How would you proceed? Just a guideline.
So they're under 60 and they've got a sudden onset of double vision. It's really about the history, and as Ian said, talking to the patient, because they may well have signs and know that they have breast cancer, in which case putting a patch on and actually reassuring them and then getting the investigations in the morning, but also looking at discs and checking that there are no other signs, checking that it isn't actually an emergency. You know, the third with the pupil and the pain is the one that always makes us go, we must do a scan now because we really can save a life with that. But actually looking at the discs, checking that there's nothing else in the history, and then probably arranging bloods and a consultant opinion and getting the eye movements and the actual diagnosis in the morning is probably going to be good enough. There's very little other than the third nerve palsy with the pain and the pupil involvement that really makes my heart sink. Obviously, we see terrible things in eye movements and Monocular and supranuclear problems, but actually they can wait a couple of days. And actually, if you haven't got time to put on a proper prism, actually just reassuring the patient and giving them occlusion so they can function for the next 24 hours until someone's in on the Monday is probably acceptable. I don't know what you think.
No, it's absolutely what we would do, but it's always nice for the delegates just to hear, because it is a time, in my experience, I think it's when we panic. It's the neuro patients, I think, that makes us as ophthalmologists panic, because, you know, one's always worried, oh my goodness, something sudden is going to happen. So thank you.
Okay,